There is one organ in your body that has never negotiated its workload. It has never requested rest. It has never taken a vacation, never paused for maintenance, never slowed down because you felt tired. From your first breath to this exact second, your heart has been contracting rhythmically, generating pressure, maintaining circulation, and sustaining life. On average, it beats around 100,000 times per day, moving nearly 2,000 gallons of blood through an intricate vascular network that stretches for tens of thousands of miles. It does this whether you are sleeping, exercising, stressed, calm, fed, or fasting. The question most people never ask is this: what truly happens to this organ when food temporarily disappears? Modern culture has conditioned us to associate hunger with danger. We have been taught that skipping meals is stressful, that the body must be fueled constantly, and that organs like the heart are fragile systems that require uninterrupted glucose supply. It sounds intuitive. The heart works non-stop, so it must need non-stop fuel. But physiology does not operate on intuition. It operates on evolutionary design and biochemical flexibility. And when you examine what actually happens inside cardiac muscle tissue during periods without food, the story becomes far more sophisticated than the fear-based assumptions suggest. This is educational content, not medical advice. If you have cardiovascular disease, arrhythmias, are on blood pressure medication, anticoagulants, or any heart-related therapy, consult your physician before altering your eating pattern. The purpose of this video is to explain mechanisms, not to prescribe treatment. With that clarity established, let's move step by step through the metabolic timeline of fasting and explore what your heart is actually doing behind the scenes. Immediately after you finish a meal, your metabolic state is defined as the fed state. Blood glucose rises, insulin is released from the pancreas, nutrients circulate. Cells throughout your body absorb glucose and fatty acids. Your heart at this moment has access to multiple energy substrates. However, here is a critical misconception. Even in the fed state, the heart does not primarily rely on glucose. In fact, under normal conditions, approximately 60 to 90% of the heart's energy is derived from fatty acid oxidation. Glucose contributes, but it is not the dominant fuel. Cardiac muscle is metabolically distinct from skeletal muscle. While skeletal muscle shifts dramatically based on activity level and carbohydrate availability, the heart prefers a steady, high-yield fuel source. Fatty acids provide more ATP per molecule compared to glucose, making them an efficient long-term substrate for a continuously active organ. This is not a survival backup system, it is baseline physiology. Your heart has been a fat-oxidizing engine since infancy. As hours pass after your last meal, insulin levels begin to decline. Glycogen stored in the liver starts to break down to maintain blood glucose within a tight physiological range. Importantly, your body does not allow glucose to crash dramatically in healthy individuals. Homeostatic mechanisms tightly regulate this process. During this early fasting window, typically the first 8 to 12 hours, your heart continues operating with remarkable stability. There is no internal alarm, no metabolic emergency. What changes is the hormonal environment. Lower insulin signals adipose tissue to release stored fatty acids into circulation. These free fatty acids increase in the bloodstream and become even more available to tissues like the heart. Because cardiac cells are already equipped with dense mitochondrial networks and enzymes for beta oxidation, they efficiently increase fatty acid utilization without disruption. From the perspective of cardiac metabolism, this shift is not stressful, it is adaptive. Around the 12 to 16-hour mark, depending on individual metabolic health, liver glycogen stores become significantly depleted. The liver then initiates ketogenesis, converting fatty acids into ketone bodies such as beta-hydroxybutyrate and acetoacetate. Ketones are water-soluble molecules capable of crossing cell membranes with ease. They serve as an alternative energy substrate for the brain, skeletal muscle, and critically, the heart. Here is where the conversation becomes especially interesting. The heart does not merely tolerate ketones, it utilizes them efficiently. Ketone oxidation produces ATP with a favorable energetic profile and may generate less reactive oxygen species per unit of energy compared to certain other fuels. In simplified terms, ketones can function as a clean-burning fuel under specific physiological conditions. This does not mean glucose is harmful or that ketones are superior in every context. It means metabolic flexibility allows the heart to operate across varying fuel landscapes. Evolutionarily, this flexibility was essential. For the majority of human history, food availability fluctuated. Periods of abundance were followed by scarcity. Our ancestors routinely experienced fasting intervals lasting far longer than modern overnight gaps. During those periods, physical activity did not cease. Hunting, migration, and environmental vigilance required cardiovascular endurance. The hearts that survived were those capable of shifting fuel sources seamlessly. That programming remains embedded in human physiology. Recent molecular research has identified enzymes involved in ketone metabolism within cardiac cells, including BDH1, which facilitates the conversion of ketone bodies into usable energy. When fasting becomes a consistent pattern rather than a random event, gene expression related to mitochondrial efficiency and substrate utilization can adapt. This suggests that intermittent fasting practiced responsibly over time may enhance metabolic efficiency at the cellular level in some individuals. However, adaptation requires consistency and health stability. It is not triggered by a single skipped meal. Another compelling observation emerges from heart failure research. In patients with compromised cardiac function, studies have shown an increased reliance on ketone metabolism compared to healthy hearts. Failing hearts appear to upregulate enzymes associated with ketone utilization. Scientists are investigating whether this represents a compensatory mechanism, a metabolic attempt to extract energy more efficiently under stress. This does not mean fasting treats heart disease. It does indicate that ketones are not foreign to cardiac physiology. They are part of the metabolic toolkit. At this stage, it is crucial to emphasize nuance. Not all fasting approaches are identical. Time-restricted eating, alternate-day fasting, prolonged multi-day fasting each produces different hormonal and metabolic profiles. Additionally, individual variability matters. Someone with insulin resistance, hypertension, or electrolyte imbalance will respond differently than a metabolically healthy individual. Context determines outcome. What remains consistent is this: in healthy adults, short-term fasting does not inherently cause the heart to starve. Instead, the heart transitions across fuel sources within a framework it was biologically designed to handle. The narrative of fragility often oversimplifies an organ that is metabolically resilient. The more accurate question is not whether the heart can survive temporary food absence, but how effectively it can adapt. And adaptation is the defining characteristic of human physiology. If metabolic flexibility is the foundation, mitochondrial efficiency is the engine. Inside every cardiac cell are thousands of mitochondria, microscopic structures responsible for converting fuel into ATP, the molecule that powers contraction. The heart contains more mitochondria per cell than almost any other organ in the body. That is not accidental. Continuous contraction requires continuous energy production, and mitochondrial performance directly determines cardiac resilience. During periods of consistent caloric excess, particularly in the context of high insulin and chronic overfeeding, mitochondria can become metabolically strained. Elevated glucose and lipid overload increase the production of reactive oxygen species, byproducts of cellular respiration that, in excess, contribute to oxidative stress. Oxidative stress is not inherently bad. It is part of normal signaling. The problem arises when production exceeds antioxidant capacity over long periods of time. Short-term fasting appears to alter this environment. When insulin declines and substrate flow becomes more regulated, mitochondrial respiration may become more efficient in some individuals. Ketone metabolism, in particular, has been studied for its potential to produce ATP with a different redox balance compared to glucose. Some experimental data suggest ketone oxidation may generate fewer reactive oxygen species per unit of ATP under specific conditions. This does not mean fasting eliminates oxidative stress. It suggests that fuel source matters in how cellular energy is processed. In addition to fuel shifts, fasting influences cellular housekeeping processes. Autophagy, often described as cellular recycling, can be upregulated during energy deprivation. Autophagy allows cells to break down damaged proteins and dysfunctional mitochondria, making room for newer, more efficient components. In cardiac tissue, maintaining mitochondrial quality is critical. A dysfunctional mitochondrion is not simply inefficient, it can become a source of inflammatory signaling and metabolic instability. Human research on autophagy in the heart is still developing, and much of the detailed mechanistic work comes from animal models. However, the broader principle is well established. Intermittent metabolic stress, when controlled and not excessive, can activate adaptive repair pathways. This concept is known as hormesis, the idea that mild stress can stimulate resilience. Exercise operates on the same principle. The key variable is dose. Now, let's address something practical and often overlooked. Electrolytes. When you eat less frequently, insulin levels decline. Lower insulin signals the kidneys to excrete more sodium. As sodium is lost, water follows. This is one reason people often experience rapid water weight loss early in fasting protocols. However, sodium is not merely a fluid regulator, it plays a central role in cardiac electrical conduction. Your heartbeat is controlled by finely tuned ion gradients involving sodium, potassium, calcium, and magnesium. These electrolytes maintain the electrical impulses that coordinate contraction. If levels drop too low, especially sodium or potassium, arrhythmias can occur. In healthy individuals, mild electrolyte shifts are usually well tolerated. But prolonged fasting without adequate hydration and mineral intake can increase the likelihood of palpitations, lightheadedness, or irregular heartbeat. This is not a theoretical risk. Emergency rooms frequently see cases of dehydration-related arrhythmias, particularly in individuals combining fasting with intense exercise or inadequate fluid intake. The solution is not to avoid fasting entirely, but to approach it intelligently. Adequate hydration and, in some cases, electrolyte supplementation, particularly sodium, can stabilize the internal environment. Anyone with known cardiac arrhythmias should not experiment independently. Blood pressure is another important consideration. In many studies, intermittent fasting and caloric restriction are associated with reductions in systolic and diastolic blood pressure. This may be mediated by improved insulin sensitivity, weight loss, reduced sympathetic nervous system activation, and improved vascular function. However, individuals on antihypertensive medications may experience exaggerated drops in blood pressure if fasting is initiated abruptly. Dizziness upon standing, known as orthostatic hypotension, can occur. Again, context matters. Fasting is not a universal prescription, it is a metabolic tool. Tools require skill. Now we need to address a study that received widespread media attention in 2024. Researchers presented data suggesting that individuals who confined eating to an 8-hour window had a higher risk of cardiovascular mortality compared to those who ate across longer windows. Headlines were immediate and dramatic. However, a closer look reveals important limitations. The data were derived from dietary recall questionnaires in which participants reported eating patterns over short observation periods. Observational studies can identify correlations but cannot establish causation. They cannot fully account for confounding variables such as baseline metabolic health, smoking status, socioeconomic factors, medication use, or pre-existing disease. It is possible that individuals restricting their eating window were already engaging in dietary changes due to health concerns. Reverse causation cannot be excluded. Subsequent expert commentary emphasized caution in interpreting the findings. Long-term randomized controlled trials specifically examining time-restricted eating and hard cardiovascular endpoints remain limited. Science evolves through accumulation of evidence, not single data points. On the other side of the literature, multiple trials and meta-analyses have demonstrated improvements in cardiovascular risk markers with structured fasting protocols. These include reductions in fasting insulin, improved lipid profiles in certain populations, decreased inflammatory markers such as C-reactive protein, and modest reductions in body weight. The magnitude of effect varies widely between individuals. This duality highlights an essential principle: biomarkers are not outcomes. Lower insulin or improved cholesterol ratios are promising indicators, but they do not automatically translate into reduced heart attacks or extended lifespan. Long-term cardiovascular health depends on a complex interaction of genetics, diet quality, physical activity, sleep, stress management, and medical care. What fasting appears to offer is metabolic flexibility. It reduces constant substrate influx and may give regulatory systems periodic relief. Whether that translates into measurable long-term cardiovascular benefit likely depends on the broader lifestyle context. Let's bring this back to the central question. Does the heart need constant feeding? From a physiological standpoint, no. The heart requires continuous energy but not continuous eating. Those are not the same thing. Energy can be derived from stored substrates. In fact, relying exclusively on external intake without metabolic switching may contribute to rigidity rather than resilience. However, there is a clear boundary. If during fasting you experience persistent tachycardia, irregular rhythm, chest pressure, unexplained shortness of breath, severe dizziness, or fainting, those are not adaptation signals. They are warning signs. Break the fast. Rehydrate. Replace electrolytes. Seek medical evaluation if symptoms persist. Resilience does not mean ignoring red flags. It means understanding your physiological limits. The heart is not fragile, but it is precise. It thrives on balance, and balance requires awareness. To understand the full picture, we need to zoom out. The debate is often framed incorrectly. It is not fasting versus eating. It is metabolic flexibility versus metabolic rigidity. The real question is whether your cardiovascular system benefits more from constant nutrient influx or from periodic transitions between fed and fasted states. In a continuously fed environment, especially one high in refined carbohydrates and processed fats, insulin levels rarely return to baseline. Chronic hyperinsulinemia is strongly associated with insulin resistance, endothelial dysfunction, and increased cardiovascular risk. When insulin remains elevated, fat oxidation is suppressed. The body becomes less efficient at accessing stored energy. Over time, this metabolic inflexibility may contribute to weight gain, visceral fat accumulation, and systemic inflammation, all recognized risk factors for heart disease. Intermittent fasting, when practiced in a structured and nutritionally adequate way, may interrupt this constant insulin signaling. Lower fasting insulin levels are consistently observed in many time-restricted eating studies. Improved insulin sensitivity allows cells, including cardiac and vascular cells, to respond more effectively to metabolic signals. Again, this does not mean fasting is required for heart health. It means that constant overfeeding may not be optimal. Another variable often overlooked is circadian rhythm. The cardiovascular system follows a biological clock. Blood pressure, heart rate variability, endothelial function, and hormonal secretion fluctuate over a 2-4-hour cycle. Eating late at night, particularly large meals, can disrupt circadian alignment and negatively influence glucose metabolism. Some evidence suggests that earlier time-restricted feeding may produce better metabolic outcomes than late-window eating. Timing may matter as much as duration, but we must establish boundaries. Fasting is not appropriate for everyone. Individuals who are pregnant or breastfeeding, those with a history of eating disorders, advanced diabetes requiring insulin, severe underweight, chronic kidney disease, or unstable cardiovascular disease should not initiate fasting without direct medical supervision. Adolescents in growth phases also require consistent nutritional intake. Biology is contextual. For healthy adults considering fasting as a metabolic tool, the approach should be progressive rather than extreme, starting with a 1-2 hour overnight fast. Something many people already do unintentionally is physiologically reasonable. Extending gradually to 14 or 16 hours if tolerated allows adaptation without shock to the system. Abrupt multi-day fasts without preparation increase the risk of dehydration, electrolyte imbalance, and excessive stress hormone activation. Hydration remains foundational. Water intake should be adequate. Sodium intake may need modest adjustment, particularly during longer fasting windows. Potassium and magnesium from diet or supplementation may support electrical stability, but indiscriminate supplementation is not recommended without need. Monitoring how you feel, energy levels, heart rhythm, sleep quality, mood provides valuable feedback. Exercise integration also matters. Moderate aerobic activity during fasting is generally well tolerated in metabolically healthy individuals and may even enhance fat oxidation. However, high-intensity training combined with prolonged fasting without electrolyte support can provoke dizziness or palpitations. Listen to physiological signals rather than ego-driven goals. Now, let's return to the heart itself. What makes this organ extraordinary is not just its endurance, it is its adaptability. Cardiac muscle can oxidize fatty acids, glucose, lactate, ketones, and even certain amino acids. Few tissues possess this range. This flexibility is protective. It allows survival across fluctuating environmental conditions. When food is absent, the heart does not interpret that as catastrophe. It interprets it as transition. Stored substrates become available. Hormonal signals recalibrate. Mitochondria adjust fuel preference. In metabolically healthy individuals, heart rate often remains stable. In some cases, resting heart rate may even decrease slightly over time with structured fasting combined with improved metabolic health, though individual responses vary. One of the most profound misunderstandings in modern nutrition is equating hunger with harm. Short-term hunger in a healthy individual is not equivalent to nutrient deficiency. The body carries stored energy specifically for temporary scarcity. The heart evolved within this framework. It was never designed to rely exclusively on incoming glucose every few hours. However, long-term severe caloric restriction without adequate nutrient density is harmful. Protein deficiency, micronutrient depletion, and chronic stress can damage cardiac muscle. There is a difference between intermittent metabolic rest and sustained malnutrition. Responsible fasting never compromises nutrient quality during feeding periods. We also need to acknowledge psychological context. If fasting becomes obsessive, anxiety-driven, or identity-defining, stress hormones may rise chronically. Elevated cortisol and sympathetic activation can increase heart rate and blood pressure. Cardiovascular health is not merely about fuel source, it is about overall physiological balance. The most evidence-supported pillars of heart health remain consistent across decades of research: maintaining a healthy body weight, engaging in regular physical activity, consuming a nutrient-dense diet rich in fiber and unsaturated fats, sleeping adequately, avoiding tobacco, moderating alcohol intake, and managing stress. Fasting may complement these pillars for some individuals. It does not replace them. So where does this leave us? Your heart is not fragile. It is not dependent on constant feeding. It is metabolically versatile and evolutionarily prepared for short periods without food. In healthy individuals, structured intermittent fasting can coexist with stable cardiac function when hydration, electrolyte balance, and nutritional adequacy are maintained. But the goal is not endurance for its own sake. The goal is metabolic competence, the ability to switch between fuel sources without instability. That is resilience. That is flexibility. That is what evolution selected for. The next time you delay a meal and feel the first wave of hunger, understand what is happening beneath the surface. Glycogen is adjusting. Fat stores are mobilizing. Hormones are recalibrating. Your heart is continuing its work quietly, precisely, efficiently. It is not panicking. It is adapting. And adaptation, when approached intelligently, is one of the most powerful capacities your body possesses. If this discussion expanded your understanding of how your heart functions during fasting, share it with someone who may be questioning whether skipping a meal is dangerous. Leave a comment describing your experience with time-restricted eating energy levels, heart rate changes, or anything unexpected. The collective data of real experiences, when interpreted responsibly, enriches the conversation. In our next deep dive, we will examine what happens to the brain during the first 24 hours without food, how neurotransmitters shift, how focus changes, and whether mental clarity is biological or psychological. Because the heart is only one piece of the story. Your body has been adapting for millions of years. We are only beginning to understand how.